The information shared on the Allo podcast is not intended as medical advice. Your medical care decisions should be made in consultation with your physician who is familiar with your specific case. Hi, welcome to the Allo podcast from the Allo Hope Foundation. I'm Bethany Weathersby.
And I'm Molly Sherwood. And today we're not messing around because we have important things to do.
Yes, we actually stole a doctor for the hour, but we have to give him back pretty quickly after this to his tiny little patient. So we're going to be on time and stick to the plan.
Yes.
Yes.
And your jerry-rigged microphone is actually really hanging in there right now. Can you please display?
Oh my gosh.
Show us your situation.
This is what's happening here.
Just for a microphone in a shoe on a jar.
It's not even a clean shoe, you guys. But I was going to have some apples and peanut butter for lunch, but now I'm not.
Not for you. No, not today.
Nope. We're having a microphone instead.
That's okay. That's okay. Like true podcasters. Okay. Well, yes, we cannot take away any longer from the tiny patients. So let's dive in. This is going to be a fun episode because we get to do it with a new but wonderful friend of ours, Dr. Tim Bahr. He's been working with us closely on some of our own research projects, and he's always such an awesome advocate for our community. He also always tells his alloimmunized patients about the Allo Hope Foundation when given the chance, which we so appreciate. Mm-hmm. So welcome, Dr. Bahr.
Thanks for having me on. We really appreciate you guys, and it's a terrific foundation to work with. We really enjoyed it.
Yay. Okay, Dr. Bahr, will you tell us about your background and how you became so interested in HDFN? It's actually kind of rare that we see a neonatologist who's like super into HDFN.
Yeah. Well, I'm a neonatologist in Salt Lake City, Utah. I'm an assistant professor of pediatrics with Intermountain Health in the University of Utah. I came to Utah about 6 years ago. I grew up here, then trained around the country. In fact, Molly and I share a common time, or not a common time, but we both spent some time in Iowa City, Iowa, when I was in medical school at the University of Iowa. But when I finally came back to Utah, I was applying for fellowships around the country and was looking for a research mentor. And the research mentor I found here was Dr. Robert Christensen, and Bob's awesome. He's 76 and still very active in research. We're meeting with the NIH today, and we work together most days of the week to study neonatal hematology. And Bob is I think the only person in the country boarded in pediatric hemonc and also neonatology. So he is actually a pediatric, or he's sort of the father, or done a lot of the work in what we call neonatal hematology. One of our areas of interest is hemolytic conditions. And so that naturally, alloimmunization is, I think, a very compelling, very important disease process that we're trying to understand more about. And so Bob's, done work in alloimmunization and other hemolytic anemias for many decades, and this is one of the areas that we work in, and trying to be one of the areas of focus for me. I think there's just it's a fascinating process, and there's so much work to be done.
There really is, and we so appreciate you for what you do in this space. And I think patients are, we've been dying to ask you a lot of the questions we're going to be asking today, and we posted online sharing that we were going to be talking to you. A bunch of moms were just chomping at the bit, and they gave like 5 questions each, some of them. So it was just great to get to sit with you and ask you these questions today.
Terrific.
And we actually touched on your research with your colleagues about that super cool end-tidal carbon monoxide thing that you do to screen for fetal anemia in the mom's breath, which is bonkers. And we talked about it like at the end of last season with Dr. Moise, but now we have you doing it yourself. So maybe you can tell us more about it.
Yeah. So one thing I love about the Allo Hope Foundation is that the moms and the leaders are so conversant and well-informed and smart. And you guys understand a lot of the biology. So, when red blood cells lyse, they release hemoglobin. I often say that red blood cells are a big sack of hemoglobin. And so one of the molecules that's released is heme. When heme is broken down, heme is broken down to biliverdin and then bilirubin. So that's why babies with hemolytic conditions get hyperbilirubinemia. In that first step, when you go from heme to biliverdin, you produce one molecule of carbon monoxide. And the only way to get rid of carbon monoxide from the human body is through the exhaled breath. So carbon monoxide is a marker of hemolysis. And so, for a handful of decades, actually a guy by the name of Jeffrey Maisels, and David Nathan at Harvard were the first ones to describe erythroblastosis, the production of carbon monoxide, or the measurement of end-tidal carbon monoxide in erythroblastosis fetalis, which is a bit of an antiquated term, but it's erythroblastosis, and it's what happens to the red blood cells when you have a baby or a fetus with severe anemia. Since then, the first device that they developed at Harvard filled up a whole room to measure the end-tidal carbon monoxide from the breath of a patient. But now we have portable devices that can measure end-tidal carbon monoxide. We've used end-tidal carbon monoxide in patients with hemolytic conditions for some time now. And so we'll measure babies with hemolytic conditions. What we're working on now, so it's common in our practice when we have a baby with severe HDFN to at birth measure their ETCO, or end-tidal carbon monoxide. But what we're investigating right now is, can we detect ongoing hemolysis in a fetus from their mother's exhaled breath while the baby or the fetus is still in utero? So we have published at least one paper. We have another series that we're going to publish. It's the data, I would say, is because you're trying to take carbon monoxide production from a fetus in their mother's large exhaled breath. You can imagine that there's a sensitivity issue there. But we do think that we are capturing some signal and able to do something there.
That would be so cool. My first thought, Bethany, I don't know
the idea, and I guess sometimes I have a hard time making a full circle, but the idea is, can we measure, can we quantify hemolysis in the fetus?
So if it could, what could a goal be that one day it could replace an MCA scan?
Yeah, MCA Dopplers have been around a lot longer, and we have a lot more experience with them. So, I think one day maybe this could be like many diagnostic tests we use in medicine. We use multiple things to get a better idea. MCA Dopplers, start to be a little bit more limited later in gestation, right? Mm-hmm. There's sort of this key period when we feel like they work. And I'm not an obstetrician, but that's what I understand, is that once we get later in gestation, late in the third trimester, they're not as helpful. I'm following a patient right now.
Right.
We're 34, 35 weeks, and we're sort of wondering, we're seeing MCA Dopplers that are 1.3, 1.4 multiples of the median, and we're like, are those accurate? So, maybe ETCO, sometimes we say ECHO, could be an additional tool to help us monitor mothers.
Wow. That could also be a really cool. Sorry, Bethany, I know you probably have thoughts about this too. But
I want to hear yours.
In underprivileged countries where they don't have access to quality ultrasound, maybe one day something portable like that could be a huge game changer. Anyway, that was
wow.
We hope it can.
That would be incredible. I have some questions. Okay. Well, does let's say the rate of hemolysis, does it directly correlate with the level of anemia though?
It does not. So good point.
Right.
So we're talking, you guys are so smart. I love it. Hemolysis, anemia can be a result of hemolysis.
Right.
So yes, we say that the end-tidal carbon monoxide is the gold standard for hemolysis, for measuring hemolysis.
Okay.
But, how anemia, or the hemoglobin concentration, or the hematocrit in a fetus or a newborn, is a product of breakdown and production, right?
Right.
So how are they compensating, and where they started at?
Yes, I was just thinking that.
And probably 20 other factors, or 100 other factors that we don't even know about.
Right. And I'm thinking of the difference in the antibodies. I have KEL, and so there's suppression of the bone marrow, so the baby's not able to then make new red blood cells well. And then other antibodies don't do that. And so if you're looking at just the hemolysis and two different types of antibody, one baby might be able to bounce back relatively quickly, and then the one with KEL is just suffering, wouldn't work
KEL,
well.
we lose the progenitors. The KEL antigen is expressed on red blood cell progenitors, so as you know, it's a tough one. Yep. So, you're right. I think one of the deficiencies we see in some of the studies that have been published, for example, I saw a question about IVIG. One of the deficiencies in the IVIG studies, although we have 2 really good randomized trials, but they were specifically for D. RHD. So some of the recommendations we make, I sort of hedge sometimes because those studies were done in babies who are D positive born to mothers with anti-D.
Yeah.
So, like you said, it's one of the great challenges, why we're fascinated. One of the reasons I'm fascinated by it is because there's heterogeneity in the disease.
Mm-hmm. Right. And I think Dr. Moise mentioned when we were talking about this, he mentioned maybe using it in conjunction with the MCA scans because, 12%, I think, rate of inaccuracy sometimes with MCA scans. I think it's 12%. Yeah. And so he was just saying when there's a doubt, you could maybe use it with this to make sure.
That's what we think. We think it could be, it wouldn't replace. I don't know if it'll be able to replace. I don't think we need, that's our goal, but can we provide more information?
Yeah. And like Molly said, in developing countries, when there's no way to monitor the baby in utero, having any type of information like this would be extremely helpful.
Yep.
Yeah. So fascinating. Okay, so should we dive in? You are the perfect person to talk about all things neonatal in the HDFN world. So we're so happy to have you here because we get so many questions from alloimmunized mothers about this phase of the disease. They've just gone through a pregnancy and they've had the intensive monitoring, and for some, they've had intensive treatments during the pregnancy, and now the baby's here, and then suddenly it's this completely different phase of the disease, and it almost feels like a different disease. And you have, all new doctors, new protocols, different way that things work. And so, and also the mother is kind of shifting from the patient to the caretaker of the patient. And so, yeah, we have so many questions for you. And I think Molly mentioned this earlier. A lot of these questions are coming from the patients and members of our Allo Hope community, and they sent their questions in. And so we are ready to get started on those.
Great.
Yes, let's do it.
And I would say that we recognize that there's a big chasm sometimes it feels like between obstetrics and pediatrics, and we're always trying to work on that, but I feel that I definitely, because we are trained on very different paths.
Right.
Pediatrics and obstetrics, we break at, so even though I'm a neonatal perinatal physician, I'm a neonatologist, it's amazing how different my training was from them. So sometimes I feel like I need to apologize to the parents that we're working on it, but I still feel like there is even just communication between obstetricians and pediatricians is not great. And it's something we struggle with in our system, but we're working on it. And that's what's most important.
That is awesome that you have that perspective too. And then then we don't sound crazy when we say it ourselves to know that you agree.
You're spot on. We know.
Okay, so I'm going to ease in slowly by painting kind of a picture here first. So we actually asked moms on our social media what they had to advocate for the most in the NICU for their HDFN baby. So I'm going to just read through these, and then I'm just curious, Dr. Bahr, if any of these are surprising to you, or are you like, yeah, that kind of makes sense, So number one that comes up all the time is no iron. That the mom does not want their HDFN baby to receive iron. They're not actually iron deficient. And there's very few exceptions, I think, where we don't see this sort of challenge come up.
Yeah.
Another mom said importance of getting some cuddle time off lights, which we'll have a question for you about that. Asking to get bilirubin checked more frequently, getting IVIG. This mom had 7 days under lights and lots of frequent Billy checks, and she was advocating for receiving IVIG for her baby. Another one just mentioned, again, getting blood work checked frequently enough. She said she had to advocate for the cord blood to be drawn and for the 6-hour blood work because the typical protocol in her hospital was not to start any labs until 12 hours old. And a couple more. This one mom says, I have a list of 13 things, to be honest. That's funny. I don't know what the list is. I think it's just a lot.
She just gave up. She's like, there's so many, I'm done.
I can't. Another one is advocating for a blood transfusion when baby needs it. One patient said she even had to advocate for the doctor to do the blood transfusion with antigen-negative blood. She didn't want to because she thought the blood would feed the antibodies.
The doctor didn't want to.
Sorry, the doctor didn't want to.
Yeah.
Anyway, anything surprising there to you?
No, because I think we have so much work to do with education. The hard thing is one of the greatest advances, one of the most bang for your buck, one of the greatest, highest value interventions that was developed 60 at least years ago now was ROGAM. Since ROGAM, I believe that the familiarity, especially among pediatricians, with this disease has really tanked. Okay, and so and most pediatricians have a minimal understanding of transfusion immunology, and so it's hard. I feel for these moms because does any of it surprise me? Unfortunately, it doesn't, just because I struggle with the same thing. Okay. If we go through those one by one, I can give you some advice. I can also tell you when you don't need to worry, when you do need to worry. I can review the evidence. So whatever you'd like to hear about, I'm happy to ramble.
Oh my gosh. What should we do, Bethany? How much time? We have like 15 more questions for you.
Sure. Let's just go through them one by one. And
Okay.
and I'm sure we'll get into some good conversations. And these are great. I want to tell you, I really appreciate being on here because I was texting and conversing with my colleagues this morning. I said, hey, these are some great questions. It really highlights what we need to focus on. We have a lot of work to do. So let's go for it.
By the way, I agree that we have some just really incredibly intelligent women in our community. And I love them so much. And the way that they advocate for their babies and educate themselves is really amazing. So just wanted to agree with you on that. What did you have to advocate for, Molly? Well, like after your babies were born.
Mostly the blood draws that I needed. I was lucky that the pediatricians they acknowledged that they weren't comfortable with this, so they just completely deferred to me, which was wonderful, which I appreciated. But that would have been a big burden on somebody who didn't enjoy reading literature all the time. That's kind of a lot.
You mean somebody who's not a nerd like us?
Yeah, exactly, for a non-nerd. But that would have been hard. And then we actually, my son who didn't even have HDFN still had an infection from his heel prick and ended up being hospitalized for IV antibiotics. So it's just interesting the things that come back even unexpectedly on the journey, that my journey was even quite short,
Yeah. Interesting. Okay. All right. So let's go to the questions. Okay. So number 1, can you still have delayed cord clamping with alloimmunization?
Yes, you guys sent me a paper, and I haven't had a chance to review it. So you tell me what that paper said. I didn't recognize the authors on it. I meant to look at it. As far as I know, yes. And, are you introducing more red blood cells with antigen? Yes, you are. But I would rather start a baby with a higher hemoglobin no matter what. Okay. And generally, there is an association between delayed cord clamping and hyperbilirubinemia. But that's okay. That's okay. We're still trying to learn a lot about hyperbilirubinemia, and I don't think that the risk of, I think the risk of the hyperbilirubinemia that might result in delayed cord clamping or the additional hemolysis outweighs the benefit of starting a baby with a higher hemoglobin and hematocrit. So as far as I know, and with the evidence that I have right now, I would not change delayed cord clamping practices in the setting of alloimmunization.
Okay, I have a question about that.
Yeah.
You said it would introduce more red blood cells with antigen. So are you talking about like the baby's blood would flow into the mother?
No.
Or you meant to say antibodies?
No.
No.
So when we do delayed, and probably antibody too, but the idea with, so the placenta, one of the misconceptions a lot of people have, the placenta is a fetal organ and it contains fetal blood. You guys probably know that. Okay. And if I immediately clamp the cord when a baby is born, immediate cord clamping, then there's a significant amount of blood. Probably, I'm sorry, I can't quote the numbers great. I think probably between 100 and 300 milliliters of blood in the placenta that can be transfused into the baby. Okay. We call that placental transfusion, but really it's fetal blood. Okay.
Yeah.
So, basically, it is well known that babies that undergo 30 to 60 seconds of delayed cord clamping, that's our standard at our hospital. I would say 60 seconds is well studied. Babies that undergo 60 seconds of delayed cord clamping will be born with a higher hemoglobin and hematocrit. And I think that is beneficial, as far as I know, that is beneficial to babies born to mothers who are alloimmunized or who are affected by HDFN. Now, is this something we need to continue to study? You bet, just like everything. Because we do know that babies with polycythemia, which is a higher red blood cell count, babies that undergo delayed cord clamping tend to run a little bit higher on the bilirubin side. But as far as I know, with my best evidence, I would advocate for delayed cord clamping, even in the setting, in all babies. And particularly, I think can be beneficial in this setting.
Wow. Okay. So you're saying when they're receiving more of their own antigen positive red blood cells.
Correct.
Okay, but also in that is also the maternal antibodies, correct?
It is. Yeah.
Okay.
Because it's stuff that's already crossed the placenta. It's not like it's not like by doing delayed cord clamping, you're introducing a large concentration or just antibody. You're just, you know what I mean?
You're bringing both the good and the bad.
Both. Yeah, right. You're bringing both, but I wouldn't. I think, as far as we know, 60 seconds of delayed cord clamping is probably beneficial. I guess if I had to choose, like you said, you bring the good with the bad. Maybe. Maybe right?
We don't know.
But if I'm ever treating a baby who has a hemolytic condition, that starting hemoglobin is pretty crucial. Right?
Okay.
So one of the other moms asked about, are there things that potentiate hemolytic disease of the fetus and newborn, HDFN? Well, you can be pretty bad off if you have a preemie who has the anemia of prematurity. You're starting off with a lower hemoglobin. There are other fetal-maternal conditions that result in anemia at birth. That's something we study pretty heavily, is anemia at birth, severe anemia at birth. And if you start off, if you have a baby that suffers from a fetal-maternal hemorrhage, if you have a fetus that suffers from a fetal-maternal hemorrhage and loses a significant amount of the red blood cell mass, and you have alloimmunized, a baby that's suffering from HDFN, you're just a little bit behind the 8 ball. My chance of avoiding, one of my goals in all of my practice, because I'm a transfusion researcher, is minimizing transfusion, right?
Yeah.
And so that's, I feel like I'm starting behind the 8 ball, and I feel like it compromises my ability to avoid transfusion.
What about in like a case like mine where the Kel titers in the thousands, babies had, let's say, 7 IUTs, like my last son.
You're like, let's just say.
Okay, yeah,
but it's actually,
I'll pick one.
Wow, I didn't know that.
7 IUTs, and then he's fully donor blood.
Right.
And his hematocrit will be, somewhere in the 30s. at birth. And so do you still think
delay that clamped cord?
Yes.
Especially because
wow.
because some of that donor blood, which should be antigen negative, and not that I'm, we do a lot of research in transfusion. It's not that I love donor red cells, but those are some, you've already given the kids 7 transfusions.
Yeah.
Some of that transfused blood is in the circulation of the placenta. So certainly, I would certainly delay the cord. And I think 60 seconds.
Okay.
I would be curious to think, hey, what is this a case where we should do it even longer? Okay.
Well, sorry, this is really the last thing I'll say.
We would need to study that, though. I would not recommend that, but it's interesting when you have all of that transfused blood in the circulation.
Right. Yeah. So they would be receiving that transfused blood that's in the placenta, just kind of topping off or whatever is in the placenta.
You're building up the baby's hemoglobin and hematocrit to start life.
Yes. So, and then can they check the cord blood while that's happening? Because one reason why my doctors were like, we got to take the baby right away is we've got to make sure the baby's okay because it's such a high risk situation. And so they really wanted to whisk the baby away quickly. And so I'm just, could they have kept the baby having receiving that blood and then also done cord blood testing?
Probably not. No,
okay.
I don't think so. I'm not the obstetrician, but I think, some of the moms talked about that. The urgent need for resuscitation in the delivery room of a newborn is usually based on cardiopulmonary distress, respiratory, and in the baby's respiratory distress.
Yeah,
so if you have a kid that's crying, I guess I don't feel like 2 minutes of delayed cord clamping, another mom asked, can I see my baby for 2 minutes before they whisk them away to the NICU? Well, heck, yes.
Oh, good.
I would say yes. Because I don't feel like there is some amount of assessment I need to do. We need to determine, in some cases, I will whisk a baby immediately and put them under lights. But there's some amount of testing we need to be doing. There's already things we can start doing while the baby bonds with the mother. And I guess 2 minutes of delay, 60 seconds of delayed cord clamping, that little bit of delay, I don't think in this disease process makes life or death. It's different than a 24-weeker. So the hard thing is you're working with doctors who are trained to take care of 600-gram neonates that don't have lungs, so a lot of us are like, we're ready to zoom in there, intubate a baby and get them ventilated,
right.
And I'm not trying to minimize the seriousness of this disease, but I think you guys know it's a long game,
right?
That needs immediate attention. I would almost say emergent, or it needs immediate attention, but perhaps not emergent attention within minutes. You need a team that's ready and aware of the baby, but there's no reason why a baby, in my opinion, can't bond with the mother for at least a handful of minutes while we're doing some work getting ready.
That's really good to know. Yeah, go ahead, Bethany.
Just unless, of course, they're born due to the fact that they're in distress because of severe anemia or
agreed.
IUT
if they're
that went
hydropic.
wrong.
Or something like that, that's a different story. But I would say in a baby who is crying and who is transitioning in a normal manner, I think that's fine. And note to ourselves, we'll talk about the guidelines, I'm sure they'll come up. That should be included. Let's make sure that's included. The question, is it appropriate for moms to have time to bond with their newborn? And I'm sure we can come up with some really high quality expert opinion, maybe evidence to support that in a baby who is transitioning well.
Yeah, we are all working together in multiple subgroups on creating evidence-based practice guidelines for the neonatal management of HDFN, which actually don't exist right now, which is mind-blowing. So,
it is.
Very glad it's happening. Yes, we're so excited about that. And it's really good to know your thoughts about having those couple precious minutes when the situation is not immediately urgent, because I think I've learned from Bethany, your experience and other moms' experiences, that having your baby taken from you immediately can be extremely traumatizing for these moms, especially because a lot of them may have had a history of loss, and that really exacerbates that trauma. So any opportunity for the bond is just really great to hear. Yeah.
Right. There may be times where that is necessary. Bethany brought them up. I won't say that it's never necessary. There may be times where it is necessary, but I think we can help guide our clinicians to know that this is a condition that needs immediate care and needs to be addressed immediately, but not emergently, as far as minutes. It's hard to know what verbiage to use, right? To make sure they understand the importance or the complications that can occur, but also if the baby can breathe and has a good heart rate and is transitioning, then I think it's appropriate to bond with mom for minutes.
But why does everyone push so hard to give iron for these babies, even without a ferritin test?
Yeah, I think it's because iron is, I'm really glad you asked this question, because we're actively working on iron sufficiency in the newborn. I think the bottom line is that how best to measure iron stores in the newborn, the definition of iron deficiency, and how to treat iron deficiency in the newborn are all very poorly described. Okay. So I think most pediatricians and neonatologists, when you see anemia, you expect that the body needs to increase its red blood cell production. And we use red cell growth factors like erythropoietin and darbepoietin to do that in our practice. When you do that, you need to make sure that the baby has sufficient iron to support that erythropoiesis. Now, but you bring up a great point. So I think our minds go to that. In the case of a hemolytic condition, that baby may already have, they didn't lose their blood due to hemorrhage, right? So they probably retained a significant amount of that iron. And in fact, they did retain a significant amount of that iron that was lysed, or all the iron that was lysed from those red blood cells. And so we've got a lot of work to do in this area. It's newer to me. Just this idea that babies with HDFN, even though I may be giving red cell growth factors, I don't need to push the iron quite as hard. But measuring iron in an ill infant is not an easy thing. Ferritins can be falsely elevated. So there's a lot of, ferritin is a tricky little test. And so all I'm saying is it's not as straightforward probably as people think. The one thing I was going to say though, we've been studying the axis, the hormonal axis that regulates iron absorption. And we've published a little bit on that. I think administration of enteral iron appears to be very safe, as far as we know. And so I think in babies who have sufficient iron, if you continue to administer mild doses of enteral iron, as far as I know, the body appears to regulate the absorption pretty well, and they probably just poop it right out. But it's a great point. I think just in summary, that pediatricians and neonatologists, when we have anemic babies that need to increase their red blood cell production, we have been taught to provide iron supplementation. That's why they push it. Okay. Why don't they check a ferritin? Well, because it's not that great of a test, and it takes a lot of blood actually to run a ferritin. So some of us don't love getting ferritins, and so a lot of times we just say, well, we just default to supplementing with iron. But it's a really good question, because there's not great evidence to guide our practice.
Do they understand that HDFN babies are at higher risk for iron overload?
I don't think so.
Do they understand that piece? Okay.
No, I think because it's not well described. I mean, when I talk to Ken Moise, when you talk to the experts, anecdotally will say that. And we know that a baby who's received many transfusions is at risk for iron overload. But we know that in the case of chronic hemolytics that receive repeated transfusions in adults. Do we really, is it well studied in the fetus and the newborn? No. It's not. So I think the idea that they are at risk for iron overload is not well understood, and I don't think very many people are aware of that. I don't think it's very well described in the literature. You can correct me if I'm wrong, but I don't think iron overload in neonates with HDFN is very well described.
We do have a good study from out of Leiden that shows that.
Okay.
So should we put it in the show notes, maybe?
Totally. Yeah.
Yeah,
You could put it
because
in
that's
there.
a good one. Because it also shows how babies who have not had IUTs are also at higher risk of iron overload if they have HDFN. Okay, let's do that, and then people can read for themselves.
All right, I'm going to skip down to this one about exchange transfusions. Okay. How quickly and how significantly does a baby's bilirubin improve or go down, I guess, is what I mean when I say improve, after an exchange transfusion?
I don't have the textbook definition at my fingertip. I should be able to tell you what's described in the textbooks about how much of a decrease in bilirubin, probably something like 30 or 40%, is not always what we see in practice. So the answer is it's highly variable based on the technique and how it's done. So depending on how quickly you do the exchange transfusion, which we do so few of them now, we see quite a bit of variability in the reduction of total serum bilirubin when the exchange transfusion is done. I would hope that you're going to get a reduction, of hopefully around at least 20%, hopefully more like closer to 40%. But I don't think you usually see a good 50-60% reduction.
Interesting.
So it's interesting because I think when you imagine an exchange transfusion, you figure that the bili should just totally go away because you're just subbing it all out. So it's interesting to know that's not actually the
problem
expectation.
is that although you're doing a double volume exchange, the circulation, it's ongoing. The blood continues to circulate the whole 3 hours of the procedure.
Yeah. Okay.
That's cool.
All right. We're going to just keep going through these questions. What is your opinion on doing IVIG on the HDFN baby after birth? And when would you do it?
Yeah. So there's a Cochrane review that we should probably post in the notes. The Cochrane review summarizes it pretty dang well. There's also a consensus, an experts consensus that was put out by Lanny Lieberman's group, and Bob Christensen's on it too, that discusses their opinion. The crux of the matter is the two good trials did not show, I believe the outcomes in both of them were a reduction in the need for exchange transfusion. This was done in moms with anti-D, giving birth to babies with D antigen who are D positive, Rh positive, and they did not show that IVIG was effective. There are, so that I would say that the review that was done, the experts consensus that was done by Lanny Lieberman's group up in Canada with people down here too, was a little cautious, or not just cautious, but they said, we're not so sure this is effective, because our best evidence suggests that it is not effective. They also said that there are, IVIG is a product of mixed human IVIG, and it's a little bit of a shotgun. It's just sort of it's a crude approach, right? And so there actually is a risk of hemolysis whenever you give somebody IVIG.
Really?
Yeah. So just when you read those papers, you will find that if you ask Bob Christensen, he says don't use IVIG in HDFN. Yep.
So,
but I would say that my recommendation to people is if crap hits the fan and you're heading towards an exchange transfusion. It takes me 2 to 3 hours to get blood for an exchange transfusion. In that time, I don't think it's harmful to administer IVIG, but you will come across people who do think that it's not effective. Our best trials say it's not effective. I think it's worth a shot sometimes.
That's interesting.
What about you personally, just anecdotally, using it? Have you seen, does it seem to help?
I've seen some cases where it does. Other cases, I feel like I'm pouring, giving them a normal saline bolus.
Oh, that's so interesting.
Yeah. Yeah.
Wow.
I think I've just interacting with you guys. I sense that you guys feel like it is a good option. But yes, I mean, sometimes it seems to help, but sometimes it does not.
I think the problem is, for me at least, most neonatologists in most hospitals aren't managing the disease the way that you are in your practice. And like you mentioned, a lowering of the need for exchange transfusions in your hospital. I don't know if that is the case in a lot of places. And so,
and simple transfusions, top-off transfusions,
right,
is what
and
we focus a lot on.
Right, and you're also starting that monitoring on time. You're treating the bilirubin with phototherapy right when it's necessary, and that's not what we see universally. And so I think that's why we advocate for IVIG in situations where it seems to be more risky.
Yeah.
Yeah, if that makes sense.
Yep. Yeah. I think the risk of harm is pretty low. And so when people call me and they say, "Hey, I got this kid, I think I'm heading for an exchange transfusion," and they ask me, do you think I should give IVIG? I say, well, Bob would tell you not to, but I don't think it'll hurt.
Yeah.
But I'm not Bob.
And it may help. And then I say, go ahead and do it while you're waiting for blood.
Whether you're a patient, provider, or otherwise affected by antibodies in pregnancy, we are here for you. We have great resources on our website at allohopefoundation.org. That's allo, spelled ALLO, hopefoundation.org.
So there are only 2 good trials that were done, that were randomized and are of high quality. Oh, that's interesting.
Wow, balloons.
How did I deserve that?
That was exciting. I got really excited.
I don't know, but balloons just popped up on your screen. It's pretty awesome.
That was
First
awesome.
time ever.
Two studies that are very high quality evidence, and so like the Cochrane review says that more work needs to be done. The 2 good high quality trials that were done, they were done in Brazil and the Netherlands. I'm sorry, I don't know.
You still have balloons.
I'm sorry. It's like it's celebrating the Cochrane reviews.
Yeah,
I think it's like I feel like
when you hold
your
up
hand
2
movement is triggering balloons.
Oh,
yeah, do
Wait,
it one more
will you
time.
lift your hand up again?
Yeah, do 2. Do 2. Wow,
Maybe not.
I don't know what's happening.
Just some other magic. Okay, please
right.
continue.